Dr. Irene Drmic is a clinical psychologist and postdoctoral fellow who worked with children and adolescents with autism spectrum disorder and related neurodevelopmental disorders. Her graduate work focused on examining cognitive processes, as well as examining the overlap of observable characteristics between autism spectrum disorder and co-occurring conditions. She's completed a 2-year clinical fellowship at the Hospital for Sick Children and obtained additional training in neuropsychology. She then worked as a clinical psychologist at the Autism Research Unit at the Hospital for Sick Children, providing research and clinical leadership support to several large research studies in autism spectrum disorder. One study examined the experiences, care requirements, and outcomes of individuals with autism and their families, and another the genetic causes or origins of autism spectrum disorder. She started a postdoctoral fellowship at McMaster University, the Offer Center for Child Studies, in 2011, and is currently continuing her fellowship at the Holland Blue Ridge Kids Rehabilitation Hospital. She's carrying out research to better understand factors that mediate positive treatment responsiveness and outcomes for children with autism spectrum disorder and mental health concerns, with a specific focus on anxiety disorders using a treatment program based on cognitive behavioral therapy. Irene.
Good morning. Thank you so much for the opportunity to be here to talk to you today. So, as you heard, I'm going to be talking about, autism spectrum disorders, really trying to set the stage in terms of understanding some of the cognitive and behavioral difficulties that individuals with ASD struggle with and certainly impact them in the classroom. So I'll just start off by giving you an overview of the new diagnostic criteria. There's been some changes that came out in the spring, talking about the areas of comorbidity and overlap, and a little bit of understanding about some of their learning strengths and needs, some of their cognitive profiles, and certainly what some of the implications are within the school system. So when we think about autism, we think about a spectrum, and this term spectrum was actually coined by Lorna Wing, who is a psychiatrist in the UK. She had a daughter with autism and started doing research and clinical work in the area and thought about it like a rainbow or a spectrum. So there's 7 different colors, and each of the colors represents a different dimension, and every child is its own little rainbow with different areas of strength and need. So if we look, every rainbow is different. The colors, how big the colors are in the rainbow are different. And so she said, nature never draws a line without smudging it. So when we think about autism, we think about it like a white light coming through a prism with its different dimensions. We see great variability in terms of a number of different dimensions that cluster in 2 areas. So we have social communication deficits, and we have areas of narrow interest and repetitive behaviors. And certainly we see that the manifestation varies widely. I mean, I'm sure you've heard the saying, when you've met one child with autism, you've met one child with autism, because everybody is just so different. In terms of what do we know, the latest estimates are that 1 in 88 live births, the rate is 1 in 88. Certainly it's more common in males, 4 times more common in males than females, but what we see in females is that they certainly are more severe in terms of level of intellectual functioning. The epidemiology seems to be changing in terms of we're seeing less frequently, we're seeing intellectual disabilities being reported. Part of that is really the recognition of the wider spectrum of individuals, the wider levels of ability. And we're seeing increasing prevalence rates, again, probably related to better diagnostics and this understanding of the broader spectrum. So in terms of the DSM5, the Diagnostic and Statistical Manual, there's been some changes, and again, instead of looking at it as a triad of impairments, as I said earlier, it's more a dyad of impairments. So we see persistent deficits in social communication and social interaction, and what you want to see is difficulties in all 3 of these areas. So we see difficulties in social and emotional reciprocity, again, difficulties with things like social approach or difficulties with conversation, deficits in nonverbal communication, so things like being able to use your eye contact to modulate it in a conversation, difficulties with facial expression, deficits in developing and maintaining social relationships. So again, it's not that kids don't make social relationships, they just have difficulties with aspects of social relationships. The second area is in restricted interests and activities or repetitive behaviors, and you want to see at least 2 symptoms in this area. So things like the stereotype behaviors, that insistence on sameness or inflexibility with transitions, special interests or preoccupations, and again, what's new here is this reactivity to sensory information, so certainly a recognition about the sensory issues that individuals with ASD struggle with. The other thing that's changed a little bit here is that they talk about symptoms needing to be present in the developmental period. So in the earlier DSM, they also talked about having to be early, but what they recognize here is that it may not actually be fully present until the social demands that are placed on the child exceed their ability. So really trying to recognize that in kids who have more skill may not struggle as much until the social demands get more complicated. Again, symptoms need to cause clinically significant impairment. The disturbance isn't better explained by an intellectual disability or a global delay. So a lot of things have remained the same, but the big thing is that we no longer have the 3 different categories, so autism, Asperger's, and PDD-NOS. Now it's really all under the term of autism spectrum disorder. And in terms of severity levels, there's 3 levels of severity, and it's really based on how much support is required. Okay, so in terms of long-term outcomes, there have been a number of studies that have followed adults. And really, this is a very busy slide, simply to say a number of studies have looked at outcomes based on 3 different categories. So they look at work status, residential situation, and number and quality of friendships. So what people would describe as tasks that adults are able to achieve. And when they've looked at these categories, really outcomes in general have been poor. So we see quite a wide range, anywhere from 4 to 62% have good to very good outcomes, and poor outcomes anywhere from 3 to 78%. Over time, we've seen, we started here in the 1950s up until 2002. Certainly, we've seen some improvements in terms of long-term outcomes, but it's still generally quite poor. The individuals who had IQs or their intellectual functioning was in the low average to above average range seem to have better outcomes. So the best prognostic indicators of outcome right now that we know are level of intellectual functioning, so higher level of intellectual functioning, and language attainment earlier. So why did I present this? I presented this because, one, there hasn't been a whole lot of studies over the years that have looked at long-term outcomes, and 2, the fact that they're generally poor really presses upon us to really start to focus on trying to change the trajectory for kids and starting early and trying to have better outcomes later on in adulthood. In terms of comorbidities, anywhere from 25 to 40% of individuals with ASD have some kind of associated medical condition. So if we look here, different medical symptoms or diagnoses, seizure disorders, as we heard, or epilepsy is quite common in kids with ASD, a number of different genetic disorders, neurologic or metabolic disorders, a number of sleep problems, whether it's difficulty falling asleep, disrupted sleep. Certainly we can think about the impact that has on the families and in terms of children's functioning in school. Gastrointestinal impairments, certainly a number of neurobiological conditions, so attentional disorders such as attention deficit hyperactivity disorder is quite common, learning disabilities, intellectual disabilities. Upwards of 50% of kids with ASD have some associated intellectual disability. And we see a number of other issues, motor issues, sensory issues, and certainly feeding difficulties, whether it's refusal to eat, being quite selective about what they're willing to eat, sensitivity to textures, certainly has implications in terms of proper nourishment, and again, being able to function in school and having the right foods. Another major concern that I think is starting to have more and more recognition in terms of it being an issue is the associated mental health concerns that many individuals with ASD struggle with. Many of the common disorders that we see are anxiety disorders, where we see a range of anywhere from 5 to 84% of kids with ASD have an associated anxiety disorder. I think the estimate is about 68%. And what you see often is multiple anxiety disorders as well. Upwards of 72% of kids have some kind of disruptive behavioral disorder. Depressive disorders are upwards of 50%, ADHD upwards of 30%, and less common are bipolar disorders. So really we're seeing quite a number of symptoms and actual disorders that kids are struggling with. Overall, we're seeing anywhere from 28 to 84% of kids have a comorbid mental health disorder. What's interesting is anywhere from 27 to 50% have 2 or more psychiatric disorders. There was a study that looked at kids who were referred to a psychiatric clinic, and they compared kids with and without ASD. And certainly the kids who were referred to the clinic with ASD compared to the psychiatrically referred population that did not have ASD, the kids with ASD had a higher number of comorbid disorders and certainly had more impaired functioning and required many more supports. So certainly a big issue. So why is it important for us to understand some of these comorbidities like mental health disorders? First is the prevalence, it's common. The second is the impact and the stress that it has on families, on kids. Prognosis, we know that it impacts long-term outcomes. So having some kind of mental health disorder, kids have worse outcomes. Persistence, so if symptoms are left untreated, we know that they don't get better. And what we are starting to learn is that treatments, focused, targeted treatments make a difference. And certainly the cost both to families, society, and children themselves. What do we know about their cognitive and learning profiles? So their profiles are definitely characterized by uneven patterns of development. So we see differences in uneven IQ development. For example, some kids, if we think about IQ, you could learn sort of visually or verbally, and we see discrepancies with higher, development in some areas versus others. Some studies have shown that IQ is actually stable in kids and adolescents with ASD, whereas others have not. There certainly hasn't been a lot of longitudinal studies to really understand the change or the course for kids. We do see that for kids who have a higher IQ to start with, we see more stability over time. Some of these discrepancies do diminish with development, so we see more discrepancies in childhood and pre-adolescence and fewer discrepancies in later adulthood. But as I said, there really hasn't been very good longitudinal research that has looked at the learning and cognitive profiles of kids and adults with ASD. Oops, wrong way. Okay, so what are some of the core issues that impact learning if we think about this? So there's a number of difficulties that kids with ASD have that are going to impact their learning and their functioning in the classroom. So if we think about the sensory difficulties that they have, so there's certainly been some reports of hypersensitivity or hyposensitivity. So issues such as sensitivity to sound. So a lot of the kids are afraid of the end of the day because the bell's going to ring, or they need to sit in a certain place in the classroom. So there's certainly implications in the classroom. Their perceptual understanding and their conceptual understanding. So they make sense of the world differently, and we need to understand how they make sense of the world, and they need to understand what we require of them. Difficulty with abstraction, so difficulty in generalizing information that they've learned. Difficulty with motivation. Differences in memory, so we'll see some kids have really great memory for remembering factual information, so they can tell you about every line in a movie that they've seen, but really have a hard time generalizing the learning that they're doing and then telling you sort of the gist of what they've learned, or really again conceptualizing some of that information. Language difficulties. So certainly, again, we see difficulties, we see some strengths. For example, many kids early on are hyperlexic, so they're really great readers, or they have a wonderful vocabulary, but really don't know how to use that in a conversation or in an exchange. So again, a number of difficulties that we see the impacts that they can also have within the classroom setting. Various social aspects, difficulties with attention. Again, some over-attending to irrelevant cues in the environment, and difficulty sort of attending to multiple cues, lots of attentional issues like ADHD, difficulties with anxiety, and difficulties with various executive functions. So a lot of the things that Elizabeth talked about earlier. So difficulties with planning, difficulties with cognitive flexibility or perspective taking. And certainly some of these executive difficulties that we see, even in the kids who have high IQ, who are destined, for example, kids who end up in university, really struggle. And it's not their academic performance that causes them to struggle. It's the difficulties that they have with some of the executive skills. So the difficulty planning, the difficulty attending class, the difficulties with social skills is what sometimes impedes their success in post education. So certainly implications for instruction. So when we think about assessment, we really need to think about assessing a broad array of areas. So looking at their developmental history, their ASD symptoms, their psychiatric issues, the individual differences, certainly behavior, their cognitive and language profile. So it's quite a complex assessment in order to really understand the learning profile and the learning needs of a child with ASD, and taking all of that into account. Many of the assessments that we do are your standardized norm reference kind of assessments, so things like IQ tests or looking at different behavioral rating scales. But what's important is to also start to examine functional life skills and get a good sense of that, and really start to think about including more contemporary types of assessments, such as community-based assessments, using more ecologically valid inventories, in addition to the traditional assessments that we use, and as well as getting a really good assessment of social and emotional functioning. A study was done looking at the skills, for example, of psychologists in the US, and they looked at the skills that psychologists gain and the recommendations that they make, and they certainly found a discrepancy in terms of what their training was and the recommendations that they make for kids with ASD in terms of what they think are the most important. So for example, a number of recommendations around social skills, but yet very little training in their academic programs in such areas. So certainly thinking about the kind of training that we need to do at all levels, so not just for psychologists, but for all levels of folks working within the school system with kids with ASD. There are a number of evidence-based interventions. There was a literature review that was done by it was the National Standards Project by the National Autism Center in 2009, and there are a list of different evidence-based treatments, those with established, so they rated it based on the strength of the evidence or the support that was available, and there were 3 categories. Those with established evidence, there was 11 interventions that they concluded had established evidence, some with emerging and some with unestablished. Some of them were surprising when I first looked at it. For example, PECS, the Picture Exchange Communication System, which is used quite a bit, they only has some emerging evidence at this point. And certainly cognitive behavioral interventions at that time, they only really included 2 or 3 studies. I think perhaps if it was done today, it probably would be considered as having an established level of evidence. So if you're interested, you can look at this website. I just wanted to tell you a little bit about some of the work in terms of cognitive behavioral therapy. I wanted to just highlight this in terms of it's certainly an area that has typically been done in a therapeutic setting, but there's more and more interest now in terms of how do we bring CBT practice into the classroom setting. It certainly is the treatment of choice for anxiety disorders. It's considered to have it's considered a potentially efficacious treatment now for anxiety in ASD. And in terms of CBT, basically what it is, it's about modifying maladaptive coping skills, cognitions, emotions, and behaviors with more adaptive ones. It's a treatment that's problem-focused, it's action-oriented, it's time-limited, and it's focused on the present. So normally, it would, in a clinic setting, it would maybe be about 12 sessions on average. Certainly, why do we want to bring CBT into the schools? Part of it is that anxiety symptoms, for example, interfere with a child's ability to fully be included in the classroom. Being able to do it within a school setting provides a contextual and ecologically valid environment to do this in. And certainly we know that access to mental health services is difficult for kids with ASD. In fact, my experience has been in trying to access services within the community. As soon as they find out that a child has ASD, they aren't able to provide service. And part of it is just not feeling that they have the competency to do that. So what exists? Currently, as far as I know, there's no published school-based intervention programs for managing anxiety within the school system. There are some other programs that have been done with typically developing kids and kids with ASD that are much more around social-emotional programs. What I've started to do, I'm working with a colleague of mine from Colorado who developed a program for kids with ASD called Facing Your Fears. And we just came back from Singapore about a week and a half ago. Really, we were brought in to modify the program and so that they are able to provide it within the school system with school staff with support from psychologists. So really spent the week talking about how to modify the program and thinking about how do you implement this type of a program within the school. I've also been working with the Hamilton Wentworth District School Board in providing training to their ASD team in terms of using cognitive behavioral strategies with their kids with ASD around emotional regulation. So certainly there's more and more interest in trying to bring some of these techniques into the school to support kids with ASD with some of their mental health needs. So what do we know about school-based school delivery? Certainly a growing emphasis on an inclusive model of education. A study out of the U.S. Department of Education showed that more and more kids are spending more than 80%. Participation of students with ASD in the general education curriculum for more than 80% of the day increased by 244%. So it was at 9% in 1992 and 31% in 2006. So what's the implication of this? The implication is that there's an increased demand on school-based practitioners to support kids within the classroom with the multitude of comorbidities that we're seeing, medical, mental health, learning issues. So it's certainly putting a strain on teachers and staff who are working with kids, more and more kids in the school system with ASD. So what are the implications? Really what we're seeing is that educational programs need to be based on a unique combination of the child's strengths and areas of need. We need to allow for different teaching goals at different times, given the different rates of learning, the different profiles of learning that we're seeing over time. And certainly given that there's no medical treatment for ASD, certainly education can play an important role, therapeutic role, in supporting kids with ASD in their learning and in their social development and in supporting changing the trajectory and outcomes for kids with ASD. Thank you.
Yes, okay. Thank you very much. I've long been interested in the care and education of kids with autism. My name is Howard Kaplan. I'm a trustee at for York Center on the TDSB. And as I was visiting one of my schools just about a month or two ago, an elementary school, in one of the lower grades, there were some kids with autism in the class. I don't recall if the whole class was special needs or it was just an integrative class, but a lot of the children were playing around and doing their things, and one child was just kind of lying on the floor, totally detached from everything.
Right.
The teacher told me his name. I asked about him, and so I went over to him. I knelt down, and I could tell by his name he's of Russian background, and I know a little bit of Russian.
Right.
Not a hell of a lot, but
Right.
but a little bit. So I went over to him and said in Russian, Sergey, how are you? In Russian.
Okay.
He lifted his head and he looked at me, made eye contact with me, and I said again, how are you? Как поживаешь? And he said to me, he very, very quietly, I don't know if he used his voice or not, but I could read his lips, and he said, хорошо, very good, very well. And then when I looked up at the principal, the teacher, and the education assistant who was there, they were standing there gobsmacked.
Wow.
Because they'd never seen that with Sergey. It was then that I realized what I had done, or what I had accomplished.
Right.
The thing that struck me was, they told me he was nonverbal.
Clearly not.
Clearly not. Well, limited anyway, under the right conditions. But the thing that struck me was that he actually made eye contact with me and held it for for a few moments.
Right. Right. Well, and certainly, I mean, something like eye contact, many people have the misperception that kids just don't make eye contact, and it certainly isn't that. It's the ability to modulate it in a socially appropriate way within a context. I think it certainly speaks to the complexity that we see in terms of really being able to do a thorough assessment of the child's strengths and needs, and clearly having them in an environment where clearly there's some kind of a language barrier, thinking about what the best environment for that child is, and there might need to be some additional supports or a different kind of classroom for him.
So language, even though the child was brought up in Canada, but I mean, obviously Russian is spoken at home. Right.
So certainly felt better. And I mean, certainly from what I understand, there isn't any, in terms of the research looking at a second language, I think the current thought is that there's no benefit to just doing it in one language versus having two languages, but certainly it sounds like he needs a bit more of an assessment to get a sense of what might work best for him. So.
Thank you.
Hello.
Hi.
Just Albert, Toronto Education Workers, representing EAs, ed assistants, and various other classifications, job classifications, non-teachers.
Okay.
My question to you is, we now have full-day kindergarten in full swing. When you were discussing these children, when does this assessment take place? Does it take place before they start school? Does it take place grade 1? Does it take place junior kindergarten, senior kindergarten?
Well, when it takes place and maybe when we would want it to take place are probably two different things. I mean, I think it really varies from child to child. It depends on where they live, who their doctor is. It would be nice for children to have some kind of an assessment at each of the major transition points. So whether it's entering into kindergarten, entering into high school, it would certainly be nice for kids to have a full assessment in terms of their learning and social emotional profiles. But most kids, I think, Probably what realistically happens is kids are getting diagnostic assessments typically after the age of 3. It's usually a very limited assessment in terms of whether they have autism or not. I would say very few kids are getting really thorough psychoeducational as well as sort of psychological assessments really at any time point in their life. But I would certainly like to see kids having an assessment at the beginning of school and at all of the major transition points.
But there's a lot of social emotional baggage that comes with that for parents, etc. Having their child labeled if they're running a gamut of tests at a very young age.
Right.
Some difficulties may be dealt with just by maturation, etc. And the other question is, since I'm very closely involved with educational assistants and early childhood educators, there is a lack of, and this was brought up several times, the individualized programs for students at any age. There's a great reliance on tests. It's a political issue, I'm sure, more than any other.
Right.
And so my question is, I have many members who are very much interested in training and specific training around the types of students in segregated settings or in the regular classroom, that they have no tools currently on how to assist that child in the best possible way. So do you have any thoughts on how that might be accomplished?
Right, in terms of the training piece or in terms of the, I mean, certainly, it's a complex issue.
But there are people right now out there expected to help the children. They want to help the children, and they're not given the wherewithal to do so.
Right. No, I think you're right. I think we need better tools. And back to your point even earlier about parents not wanting necessarily a diagnosis or a label, and certainly some of these assessments don't have to be with a focus of labeling. It could be more trying to profile a child's strengths and areas of need. Thinking about the kinds of tools you can use in the classroom setting, really to look at where their skills are at, and thinking about more of a response to intervention kind of model rather than a labeling type of model. It's a complex question. I'm not sure. I think there certainly has to be training for various levels of staff who work with kids, but certainly I agree with you that there needs to be some training so that EAs have the tools that they could assess kids while they're working with them. So I don't know, it's a complex one. I'm not sure what the answer is.
Thank you.
I just wanted to make a comment around the role of the parent.
Yes, hi, sorry.
I'm here to represent the TDSB Parenting and Family Literacy Centers, so we work very closely with parents of children before they enter into the school system. And just to pick up on what the previous speaker was saying, that the psychological and social implications for families in terms of early identification is huge. That the parents themselves have to go through a journey of acceptance. We know that parental denial and the reasons behind it is a huge barrier to early identification of children with any kind of developmental delay. The parent has to go through a grieving process of accepting the fact that there may be an issue, and that journey can be a long one for some parents, and that every parent already knows in their heart that there's an issue, and they have to translate that into their head. But until the parent is ready to accept the fact that their child is going to need some, extra attention within the school system, and before they get there, that relationship that needs to be built with the parent to get them on the first step is crucial.
I absolutely agree with you. I mean, I think the way our system is set up, there isn't enough follow-up for parents in terms of supporting them through that journey. And certainly when that diagnosis comes early, there's so many decisions that need to be made so quickly by parents. And really, there isn't a system in place to help parents navigate the system. So not only cope with their own grief, but also navigate what are the next steps for their child. And it's a very, it's a very confusing and scary journey for them, I would agree.
with the added complication if they're newcomers to Canada.
Right.
English may not be their first language, so even for English-speaking educated parents, it's already a struggle, and to work their way through the system. So those families have extra challenges in their journey.
Right. No, I agree. I think we need some kind of a system that has some kind of care navigator to help families, especially at the early stage. I think throughout their entire life and throughout all their transitions, but I think especially at the early stages. I mean, it's interesting. Some families. There's certainly a differential response for families. I would agree that all of them have that period of grief, but some actually find it to be quite a relief because now they understand what's going on with their child and have a sense of what to do. So it's certainly an individualized journey for every family. Hi.
Hi, I'm Lee Ford Jones, a pediatrician at Sick Children's, and it might be just a good chance to pull some of this together because as soon as tomorrow, in fact, thanks to our wonderful Toronto crowd, the EDI people, there's a meeting that a number of pediatricians from Ontario are involved with related to a pre-JK calling all 3-year-olds screening, because so much of this is going, so an effort to standardize things, and certainly get in the immunizations and the vision and corrective lenses piece as well, but and certainly there's a lot that you can get in, but it's just the experts are there to know how to bring in parents. But I'm also thinking of, besides what you've just said in terms of sort of help in that, interventional help, certainly not labeling in that regard. There's also a poverty tool that was published in the Ontario Medical Review, which is the OMA, Ontario Medical Association, which is a tool of sort of financial resources to help get families on a better financial footing and things that are very doable. It's led up by Gary Block out of St. Mike's, wonderful work down there. So I guess what I'm trying to say is maybe there's a chance now if anybody wants to be connected to that, or just give me their email or something afterwards. We can make sure that we captured people under this umbrella of leadership in Toronto Public Health.
That sounds good. Why don't we connect afterwards? Was there another question?
Hi, I'm Kelly Gallagher-Mackay from People for Education, and I was hoping you could tell us a little bit more about how the CBT in the classroom would actually play out. Is it a psychologist who's trained who comes in and does it and then gives feedback to both teachers and families? Is it teachers being trained to do it? Can you tell me a little bit more about what we're talking about here?
Yeah, I think the model is in the midst of being determined, but so there's two different models. So in Singapore, the way we were doing it was their school staff, so their EAs, it would be akin to EAs here, are going to be the ones running the program. So they're actually running it like a 10-week therapy program where they're going to have 2 or 3 kids to start working together, and the psychologist will be overseeing the work, but the EAs will actually be providing the intervention. In Hamilton, the way that we're doing it is I'm working with the ASD team, and I'm teaching them more generally in CBT principles and strategies. So we're starting off with just sort of some psychoeducation, and then the next phase will be doing some case consultation. So it's really them working with whatever individual children they're working with and trying to use CBT strategies. So 2 very different models. And I think it depends on the needs of the school, and it can certainly be tailored to meet the needs of the specific school and population.
And can I ask a quick follow-up? Is that approach being looked at outside of the autism context as well, or is this where it's being first developed?
Well, as far as I understand, I think in Peel there is a psychologist who's doing it in a more general context. I'm doing it in these 2 contexts specifically to ASD. Yeah, but there really hasn't been a whole lot of research published even within the typical literature in terms of bringing CBT into the regular school system.
I'm Tiffany Chow, neurologist from Baycrest. I'm heading up a group of people who are trying to bring education about brain health into high school classrooms, namely 9th and 10th graders. And I was really struck by your comment that there's no programs for managing anxiety in place. And is that anxiety related to ASD, or is it anxiety of any stripe in any school? Because there are a lot of kids who have social phobias, especially in high school. Anxiety about learning, things are getting more complicated once they hit high school, anxiety about leaving home to go to university or not.
Right.
And I'm new to this world, so I'd love for people to let me know if there's anything out there or what the opportunities are for growing something like that.
Right. No. So as I was saying, I mean, the work that I'm doing is specifically around anxiety and ASD, but I think there are some folks who are doing some work more generally. I think there's someone at the Peel School Board. There's a psychologist. I can get the name. I don't remember it offhand, but if we connect, I can pass along that information. But again, I don't think there's any. I mean, other than, not that I can think of. I mean, I think there's folks doing it, but there's nothing that's actually been published as of yet. So.
Okay, I think we're going to move on to